Here is the explanation for the third ECG of the ECG club. Here is the ECG and the choices on the right, and this is a very difficult ECG but gives us the opportunity to understand the formation of QRS complexes and the P waves in detail in the precordial leads as well as the limb leads. The goal of this ECG is to be able to identify the following. One is negative P waves in lead 1 and AVL, and positive P waves and QRS complexes in lead AVR. A picture where it looks like the patient has a right axis deviation. As you can see here, the QRS complex is mostly negative and the QRS complex in lead 2 and AVF are mostly positive, so it gives a picture of right axis deviation. In the precordial leads, it gives an impression that there is a regression of R waves. As you can see here, the R waves get smaller and smaller, and the S waves become larger and larger as you go across the precordium from V1 to V6. So those are the things that we want to be able to identify from this EKG, and therefore based on that we make an interpretation of the answer, which is one of these that are given on the right. We talked about this in the last ECG where we talked about left ventricular hypertrophy, but I'm going to give you a recap of the formation of the QRS complexes in the precordial leads from V1 to V5 so we can understand this EKG better. So as we talked about before, there are three parts to ventricular depolarization. The first part is this red arrow which shows the septal depolarization, and the septal depolarization goes from left to right towards V1 and away from V5 and V6, and therefore it's represented by a small R wave in V1 and a small Q wave in V5 and V6. Now part 2 is this green arrow, which is mostly the LV depolarization, which goes towards the left and towards V5 and V6 and away from V1. Therefore it is represented by a big R wave in V5 and V6 as it's going towards that lead, and a big S wave in V1 as it's going away from that lead. And the third part and the last part of the QRS is the ventricular depolarization that goes from the apex towards the base of the ventricles, and mostly also because the left ventricle is larger, this mostly represents the movement of the depolarization from the apex to the LV base rather than the RV base normally, and therefore this is seen as a small negative waveform in V5 and V6 as it goes away from V5 and V6. Normally you don't see much going towards AVR, which is located somewhere here, because the RV is not the larger part of the ventricle, the LV is. But when the RV is bigger, that apex to base depolarization will also move towards AVR, towards RV base, and therefore you can see a larger R wave in AVR when you have a right ventricular hypertrophy or right axis deviation, and then we're going to talk about this further in the following slides. This slide shows you the normal precordial transition of the QRS complexes from V1 to V6, and as you can see here, the R to S ratio, which is if you divide the R wave by the S wave, that ratio is less than 1 in V1 and V2 in a normal precordial transition, and the S waves are deeper in V2 as you can see here compared to V1. So V2's S wave is deeper than V1. Now the R wave becomes progressively bigger and bigger and bigger until it reaches about V5, and then it kind of plateaus in V5 and V6. Now if you have a left ventricular hypertrophy, so this part of the ventricle is hypertrophied, you are going to see accentuation of the normal QRS complexes. By that I mean that the S waves are going to get deeper and deeper in V1 and V2 as your left ventricle hypertrophies, and your R waves are going to get taller and taller in V5 and V6 as your left ventricle hypertrophies. Now, what happens if you have a right ventricular hypertrophy? Now, if you have a right ventricular hypertrophy, you're going to superimpose a bigger RV contraction over this same precordial transition, which means that you're going to have a bigger representation of the RV in V1 and V2, but not much is going to change in the precordial transition from V3 to V6. So you're going to see big R waves in lead V1, and you're going to see maybe a smaller S wave in V1 and V2, but then the R to S ratio still remains more than 1 from V3 to V6. The R waves don't get smaller as you progress through the precordial leads from V1 to V6 when you have RV hypertrophy. It's just that the R waves become bigger in V1 and V2, and still there are large R waves in leads V4 to V6. This is a figure to explain the P wave axis in the limb and precordial leads, but before I get to that, I wanted to explain one more phenomena regarding the QRS complexes in lead AVR, which is located in about right here. So normally the ventricular depolarization mostly moves away from AVR. So the septal depolarization, the apical depolarization, and even the depolarization that goes from the apex to the base of the ventricle moves away from AVR. So AVR, the QRS complex, is mostly negative. But imagine that the RV is so big and or the heart is rotated towards the right, then even though the initial forces, which is the septal depolarization, the apical depolarization, moves away from AVR, the final part of the ventricular depolarization, where the bases of the LV and RV get depolarized, that RV depolarization, because the RV is now bigger, there is more voltage created towards the base of the RV that goes towards AVR, and therefore in those kinds of cases, which is basically right axis deviation and right ventricular hypertrophy, you can see an R wave in AVR, not the initial portion but the terminal portion of the QRS complex, which means that you're going to see a Q wave followed by a R wave in AVR. Now coming to P waves. P waves represent both right atrial and left atrial depolarization, so right atrium and the left atrium. But most of the leads cannot discriminate between the two atrial depolarization. They see one P wave and that's it. The two important leads that can actually discriminate between the right atrial and left atrial depolarization is lead V1 and then lead 2. In V1, the right atrial depolarization comes towards V1, as you can see here, because the right atrium is just underneath V1, so it comes towards V1, and therefore you see a positive waveform in V1 as represented by this blue part of the P wave. The second part of the atrial depolarization is the left atrial depolarization, where the depolarization moves away from V1, and therefore you will see a negative waveform of the P wave in V1, which is denoted by this purple part of the P wave. So therefore in V1, the right atrial and left atrial depolarization causes a biphasic P wave. Now if you'll come to lead 2, lead 2 sees the P wave coming towards it, so it's all positive. But if the left atrial depolarization takes longer, in cases like, say for example, left atrial hypertrophy, you can see a second positive bump to the P wave in lead 2. So one other thing I want you to understand is any lateral leads, which is V5, V6, also AVL, lead 1, in all these leads, the P waves are always positive because the atrial depolarization, both towards the right atrium and the left atrium, goes towards V5 and V6 and lead 1 and AVL, so the P waves are almost always positive in these leads, and I want you to keep that in mind when we talk about P waves in the EKG that we were given in this session. So just to recap the formation of QRS complexes on the limb leads, even though we've talked about the precordial leads before, I want to just make sure you understand the limb leads better. The P waves goes always from right side to left side, and so they're always positive in lead 1 and lead AVL. So the limb leads 1 and AVL P waves are almost always positive. The QRS complexes also move from right towards left, and therefore in lead 1 and AVL the QRS complexes are positive. Now AVL is probably the most isoelectric lead in a normal heart, so which means that there is equal amount of positive and negative deflections in the QRS complexes of AVL. Now P waves also go superior to inferior, which in the atrium, and therefore P waves are almost always positive in leads 2, 3 and AVF. The P waves are almost always positive, and the same is true for QRS complexes. They go from superior to inferior, and therefore QRS complexes are almost always positive in 2, 3 AVF as well. AVR is the most unique lead where both the atrial depolarization as well as the ventricular depolarization go away from AVR, and therefore both P waves and QRS complexes are negative in AVR. So these were the choices that were given, some of them, not all of them, as answers for this particular EKG, and some of them are obviously wrong, so I wanted to clarify those choices first. The choice WPW is not true because you don't see any delta waves, and the PR interval is not short in these EKGs. Right axis deviation. Now there is definitely, as I told you in the first slide, the QRS complexes in the limb leads look like there is a right axis deviation, but that cannot explain the positive QRS complex or the positive P waves in AVR. Remember, when you have right axis deviation, your P wave axis does not change in AVR, and therefore your P wave should still be negative. When you talk about axis, you're only talking about the ventricle, so your atrium is still the same. Your P wave should be negative in AVR, and your P wave should be positive in lead 1 if you have a right axis deviation, so which is not the case in this EKG. Left posterior fascicular block. It's almost the same reason. You cannot explain the positive QRS complexes or the positive P waves in AVR or the negative P waves in lead 1. Both these should remain normal in left posterior fascicular block. In left posterior fascicular block, the axis changes, but the atrial depolarization does not change. In addition, the QRS duration is not prolonged, and the R wave peak time is less than 45 milliseconds in this EKG, which goes against left posterior fascicular block. Poor R wave progression is not the answer in this EKG because usually in poor R wave progression, the R to S ratio is less than 1, at least up to V4. But if you see in this EKG, your R waves are much larger than S waves in the precordial leads. In fact, there's only R waves, no S waves in lead V1 and V2. So that goes against just poor R wave progression being the reason for this EKG. It is not right bundle branch block, as you've already figured it out, because the QRS duration is much less than 120 milliseconds. It's narrow QRS complex. There is no RSR dash pattern or bunny ears in V1, and the S wave in V6 is not prolonged. And finally, lateral wall MI, there is no Q waves in lead 1, AVL, V5 or V6. Therefore, this is not a lateral wall myocardial infarction. Like we talked about before, right ventricular hypertrophy and right axis deviation. This actually shows you both right axis deviation and right ventricular hypertrophy. You will see a large R wave very tall R waves in V1 and V2 and almost no S waves, and therefore the R to S ratio in V1 and V2 are much more than 1, which is not the normal case in a normal EKG. So that gives you a clue that the right ventricle just underneath V1 and V2 is much larger and hypertrophy, thicker muscle, producing more voltage that causes these large R waves in V1 and V2. But what you would notice here is that the R to S ratio is still a lot more than 1 all the way up to V5 and V6. So the R waves don't get smaller. The R waves to S wave ratio is still much more than 1 all the way up to V5 in right ventricular hypertrophy, which is not the case in the EKG that was given to you. In addition, yes, you see a right axis deviation in this EKG where you can see the QRS complex is mostly negative in lead 1 and the QRS complex is mostly positive in 2 and AVF, just like the EKG that we were given. But what is not true is, as against the EKG that you were provided, the P waves are positive in 1 and AVL and the P waves are negative in AVR. As you can see here, AVR has a Q wave but followed by a large R wave because of the phenomena that we talked about before, that the right ventricle, when it hypertrophies, you have a lot more voltage going towards the base of the right ventricle, which actually is going towards AVR, and therefore you will have a bigger R wave in AVR in right ventricular hypertrophy. So you can see some features of this EKG present in our EKG. But you can see some features that go against just right ventricular hypertrophy in our ECG. Another choice that was provided to you as an answer was posterior wall myocardial infarction. In a posterior wall MI, you are basically looking at an ST elevation in the posterior walls, which you're not looking at it directly because your leads are not placed posteriorly in the body. You're placing the leads anteriorly. So you are actually looking at the mirror image of the ST elevation in the posterior wall, which is basically seen as ST depressions in the anterior leads from V1 to V3. In addition, you're seeing a large R wave in V2, and therefore the R to S ratio is usually more than 1 in V2. But in this case scenario, you will see still a normal R wave progression across the precordium from V1 to V6. So by the time you get to V6, there is a large R wave and a very small S wave. So therefore the R to S ratio is far more than 1 in V6, which is not the case in the EKG that you are provided, where the R waves get smaller and smaller. So there is a regression of R wave as you come across the precordium. In addition, in posterior wall MI, the AVR lead looks just like a normal ECG. The P waves are negative and the QRS complexes are mostly negative in AVR. In lead 1, you will usually see either a normal axis or a left axis deviation, so therefore the QRS complexes are going to be positive and your P waves are going to be positive. The single most biggest contender for the right answer in this EKG is dextrocardia. So we're going to talk about dextrocardia. As you can see here, the normal anatomy of the heart is located in the precordium with the base to apex axis towards the left side and towards V4, V5, and V6. In dextrocardia, your axis is completely facing rightwards, and therefore any leads that are on the left will see kind of like an inverse formation of the QRS complex, like in a normal ECG. For example, lead 1 and AVL, the QRS complexes are going away from 1 and AVL, so you're going to see negative QRS complexes in 1 and AVL. Remember, AVR, which is usually located on the right side, always saw the P waves and QRS complexes moving away from it. But in this case, in dextrocardia, both the P waves and QRS complexes are going towards the right side, and therefore you're going to see a positive P wave and a positive QRS complex in AVR. And finally, that looks like a left to right arm transposition of lead. So if you actually switch the right arm lead to the left arm lead on a normal anatomy without dextrocardia, you will see the same kind of QRS complexes, and I'm going to talk about that in a second. But the most important thing that I want you to focus on is the precordial leads in dextrocardia. So as you can see here, there is a poor R wave progression in the precordial leads, and as you can see here, it almost looks like they switched V1 and V2 leads in this EKG. But the most important thing is from V3 to V6, it almost looks like right-sided leads. They're just basically negative. This is how right-sided leads will look on a normal patient. So if you have a normal heart and you place all the leads on the right side, your right-sided leads will look exactly like this. So in dextrocardia, it's basically like right-sided leads, but placed on the left side, but the heart is facing towards the other side. These leads should look like a right-sided leads, which basically is just Q waves all the way around from V3 to V6, no R waves at all. So this is the normal dextrocardia, and I'm going to show you another EKG to write home these facts that we talked about much more clearer. So here is the Dextrocardia ECG up close, and we're going to talk about the findings lead by lead. So there is what appears to be a right axis deviation, which means that there is a positive QRS complex in AVF and negative QRS complex in lead 1. The QRS complex is positive in AVR. But the most important thing, as you can see here, is the P waves are also negative in 1 and AVL, and the P waves are positive in AVR. Now, when you come to the precordial leads, as I told you before, there looks like there is a poor R wave progression, and it looks like V1 and V2 are switched. As you can see here, this is how a normal V1 would look, and the R waves would get slightly bigger in V2, but here it looks like they are switched. And then from V3 to V6, you can see all these leads look like right-sided leads where there is very tiny R wave or almost no R wave at all, and just a big S wave on all these leads from V3 to V6. This is not the case in the ECG that you were given. You had a tall R wave in V1, and the R waves got a little smaller as you went across the precordium, but there were still big R waves in V5 and V6. And the last clue in the Dextrocardia ECG that I want you to pay attention to is the negative P waves in V5 and V6. As you can see here, V5 and V6, you can see inverted P waves in these leads. That is because the base to apex axis on the precordial leads in a dextrocardia is facing away from V5 and V6, so the atrial depolarization is sensed as a negative waveform in V5 and V6, and that is the most important finding that discriminates this ECG from the ECG that you were given. Two things. One is the R waves did not completely go with, you still had a big R wave in V5 and V6 in the ECG that you were given. And the second most important finding to discriminate is the negative P waves in a dextrocardia ECG, which you did not see in the ECG that you were given, where you had a positive P wave. So the final choice that you were given is limb and chest lead reversal. So I'm going to explain each of these things separately. Limb lead reversal first, and then precordial lead reversal. The most common limb lead reversal is switching the right arm lead to the left arm and the left arm lead to the right arm. So that's the most common one. Now, if you want to look at each of the different ways people can switch leads, there are multiple different combinations in which you can switch. You can switch left arm to left leg. You can switch left arm to right leg. You can switch right arm to right leg, and all different ways. Also, you can also put one of these limb leads on your precordium and then put your precordial lead here on the limb. So there are several different ways you can switch, and you can Google it to see all the criteria that you can use to discriminate these switches. But the most common lead switch is switching the right arm to the left arm, which is what we usually have, and which is what we've been given in our ECG. So when you do that, normally your forces go from the right arm to left arm, so towards the left. Here the forces are going towards the right arm, so therefore instead of lead 1, what you're having there is the inverse of lead 1, and I'm going to show you that in a second. And because of the switch, your normal lead 2 becomes lead 3, and your normal lead 3 becomes lead 2. The only lead that did not get any changes because of this lead switch is AVF, and then I'm going to show you this EKG in a second. This is an ECG where the limb leads have been switched. Now the precordial leads in this ECG is not switched, and therefore I will show you the difference between the ECG that you were given and this EKG where only the limb leads were switched. So if your limb leads were switched, which means that in the case where your right arm lead is placed on the left arm and the left arm lead is placed on the right arm, as I showed you in the slide before, your lead 1 is the inverted lead 1. So when you see lead 1 here, you basically, if you prop it up, if you turn it upside down, this is how your normal lead 1 should look like if you flip it upside down. Now this one is flipped upside down, so that's inverted lead 1. Your lead 2 in this EKG is your actual lead 3, and your lead 3 in the EKG that you were given is the actual lead 2. So if you switch these two orders, then you would be fine. Now AVR and AVL, remember your right arm and left arm were switched, so therefore your AVR that was given in the EKG is your actual AVL. That makes sense with the positive P wave and positive QRS complex. And the AVL that you are given in the ECG is your actual AVR, which makes sense again because there is negative P waves and negative QRS complexes. The only limb lead that is not affected by the switch is lead AVF. There is no difference in this EKG from a normal EKG, so this lead was not affected at all. Now, when your limb leads were switched and your precordial leads were not switched, you know that this is not dextrocardia, because in dextrocardia, remember, you will see the same kind of ECG. Your P waves will be positive in lead AVR, your P waves will be negative in lead 1 and AVR. You will have a right axis deviation, and also you will have a negative QRS complex in lead 1 and AVL, right? So this looks exactly like the dextrocardia ECG. So why is it not dextrocardia? Because if you looked at your EKG, the one that you got, you had positive P waves in leads V5 and V6, which should not be the case in dextrocardia. In this case, it's not a big deal because you also have good R wave progression, which goes against dextrocardia, right? So the R waves get bigger and bigger as you go across the precordium from V1 to V6. So that tells you that it's not dextrocardia. In addition, your P waves are also positive in V5 and V6. So you were given an ECG that looks like dextrocardia with right axis deviation, negative P waves in lead 1 and AVL, and positive P waves and QRS complexes in lead AVR. Except the precordial leads do not align with the dextrocardia. There is still big R waves in leads V3 to V6 and P waves in V5 and V6 that are positive, which shouldn't be the case in dextrocardia, right? Then it could be left arm to right arm lead reversal, except the precordial leads are still not in alignment with just a left arm to right arm lead reversal, as there is regression of R waves across the precordial leads. So what else could it be? Well, one option is switching of the right arm lead to left arm lead, and also switching the precordial leads, where the precordial leads are completely switched in the reverse direction, with V1 being attached most laterally and V6 being attached most anteriorly to the right of the sternum. So the EKG waveforms will look exactly opposite to what is normal. So here is normal, where there is a small R wave in V1 that gets progressively bigger and bigger up to V6, where the R wave is much bigger than the S wave, so the R to S ratio is more than 1. Now, when you attach the leads in the opposite direction completely, it is the exact opposite of what you would find with the biggest R wave in V1 and the smallest R wave in V6. The way to read this ECG would be to go backwards from V6 to V1. So this is V1, V2, V3, V4, V5, and V6, and that would give you what a normal ECG on this person should be. One of the findings that I want you to pay attention to is the positive waveforms of the P waves in V5 and V6. So there are positive P waves in V5 and V6, which is not the case in dextrocardia. Only in a lead switch you will see these positive P waves in V5 and V6. So here is the summary of the ECG that you were provided. The ECG that you were provided shows what looks like a right axis deviation and big R waves in lead V1, which goes along with right axis deviation and right ventricular hypertrophy. Except the P waves in lead 1 is negative and the P waves in lead AVR is positive, which goes against just right ventricular hypertrophy or right axis deviation. In addition, the R to S ratio is less than 1 in V5 and V6. So R waves are much smaller than the S waves in V1, V5 and V6, which should not be the case in right axis deviation and right ventricular hypertrophy because the normal R waves are preserved in right ventricular hypertrophy. So what could it be? Could it be dextrocardia? Well, the limb leads support that. There is right axis deviation, there are inverted P waves in lead 1, there are positive P waves in QRS complexes in lead AVR. So the limb leads support it, but the precordial leads do not. For example, V4 to V6, you still have big R waves, which goes against dextrocardia. Also, the fact that the P waves in V5 and V6 are still positive goes against dextrocardia as well. So therefore, the one diagnosis that explains all the findings is right arm to left arm plus a complete precordial lead reversal. So here is the answer for the EKG, which is limb and chest lead reversal. See you next week with another ECG.